We'll move on to Esther Kruitwagen now. After studying medicine, Esther was trained as a rehabilitation physician in the Utrecht Rehabilitation Medicine Network in the Netherlands. After her training, she first worked in the Hoogstraat Rehabilitation Centre with a focus on neurorehabilitation. Since 2006, she has worked at the UMC Utrecht and specialised in care for adult patients with muscular disease, with special attention first to patients with ALS and also to adults with SMA. Her research focuses on the quality of life and social participation of people with a muscular disease, in particular ALS, and adults with SMA. She's the coordinator of the National Care Network for ALS. In this role, she's involved in research and implementation of eHealth, educational material, and guidelines for chronic ventilation. These projects are focused on people with muscular diseases, loved ones, children, and medical professionals. She regularly gives lectures. Esther's talk today will focus on quality of life and care for people with locked-in syndrome. She's going to speak about her experiences as a physician and a researcher. Welcome, Esther. Good to have you with us.
Thank you very much for having me. I hope you can see my slides, if everything's okay like this. It's wonderful. Thank you for the invitation. I'm a physician in rehabilitation medicine in the Netherlands, like my Norwegian colleagues you just heard. And I work, at the moment, I work mainly with patients with ALS and other neuromuscular disease. But before this, I also work with other patients in a neurorehabilitation unit of the Hoogstraat. Wait, I hope my presentation. Oh, okay. There he is. Well, you asked me to talk about quality of life. That's an interesting topic because quality of life, I think, is a very easily used term for a lot. And it's sometimes I think it's too easily to use because it becomes like, well, a whole big term for something which you don't really know what it is for this patient and how to influence it. So on your left up, you see the ICF scale, which is the basis of a rehabilitation medicine, the way we talk about our patients and the model we use to talk about the impact of health condition. And you see body functions, activity and participation, social participation, a very important outcome of functioning. And obviously the environmental factors and the personal factors which influence all these segments of the health condition. And then we think quality of life or health-related quality of life is kind of a concept which is closely related to participation. I think when you're talking about patients with severe disorders like these patients with locked-in syndrome, you must never forget to also talk about all dimensions of life. I think the focus on physical care and physical problems is always very strongly available. But let's talk about all dimensions of life and also include the position of spirituality in life. That's not, it's not only for ALS. I mean, maybe you would think in ALS patients very logical because it's a palliative disease. But I think for actually for all patients with a chronic disease with severe restrictions, it's very important to talk about all four dimensions. And then you have the scheme of Huber, and Huber is a Dutch scientist, and she has a kind of the positive quality of life scale, and this is what you see. And what's very important about this scale is that it talks about positive health. So it's not about describing what you're missing and the functions you cannot do and the lack of quality of life, but it's asking in which functions, of which dimensions you're able to do, how do you want to participate. So it's strongly focused on what you can do and where your choices are. I think that's a much more appreciative model of talking about someone's life. So as a doctor and a scientist, obviously, when I meet someone with locked-in syndrome, I work in university hospital, so often in an acute situation. I sometimes, of course, I look into literature and see what we know about determinants of quality of life. Also to talk to ICU doctors, and you understand why that's so important. but I will go in that later. And then you find that determinants of quality of life, what do we know about it? Like we heard before, yes, few studies, unselected, mixed etiologies is all true, but I can give you some results. It's kind of a small review. We saw in a French survey that a lot of patients reported pain in the lower limbs, but a lot of patients also did not communicate the pain to others. I know that from other diseases, patients I treat, also ALS, that pain is an uncommunicated problem. Obviously, patients think it's part of the problem, they say, but it's uncommunicated. Then a living situation obviously is a determinant of quality of life. The people you have around you, the city you're living, or the environmental situation. And then family situations for me is a very important topic. We focus a lot on caregivers in Utrecht, and also among locked-in syndrome patients, we find that caregivers ask for more attention. They rate the need for information. They need a lot of communication about the situation, the disease, an acute situation, but also in a subacute situation. The fact that they don't know exactly the prognosis of what they expect for themselves and the impact on the young family, for instance, is it's a big burden for caregivers. And experience feelings of anxiety and depression, and also are the ones who under-communicate their problems. And then determinants like cognition and behavioral changes. They are there, and they are not widely reported, but like my colleagues also, we do recognize that sometimes there are cognitive and behavioral changes, and which is, well, you could say it's logical when you see that you have patients with multiple cerebral lesions, for instance, or ALS. Next slide, please. So we know that the disease duration over the years is positively related to quality of life. So patients start with a lower quality of life, and then in the course of time, especially when patients change from complete to incomplete, the quality of life they report is often higher, but also complete patients can report a high quality of life, which is what we also know from other diseases. I go in that later. The fact that you have good communication tools like we saw for Anne obviously is very important. The fact that you can use it is also very important, and Anne has a lot of capabilities to do so. But when you're only able to use yes or no code, and you have a complete list, then it has impact on quality of life. Physical function is not as strongly related to quality of life as would expect it, by caregivers who don't, or by healthcare professionals with not much experience, because we know that for a lot of diseases, we think that physical function is strongly related to quality of life, but actually it doesn't really comply for all of the determinants for the quality of life. Anxiety and suicidal thoughts, often in the first phase, cannot be others than negatively correlated to quality of life. And autonomy, very important. The way you can perform your activities, or the way someone takes care of you, and the fact that you have control over that. Like we heard about the IPA, the questionnaire about autonomy, and I think that's a very important determinant and something to strive for during the whole process. Next slide, please. And all comes in the whole psychological process patients go through, not only with locked-in syndrome, but every patient who, has an acute or subacute or progressive disease. With every change in the physical functioning, someone has to adopt and uses his coping style he's learned during life, but he's also learning during having the disease. And that is the reason why a lot of patients, we call that a response shift, and with a good quality of life, far much higher than a lot of healthcare professionals would expect at front. So we all go through these phases, and the fact that you can appraise the situation and learn from it, and use your experience you have to your life, your adaptive tasks, and your coping skills lead you to have a lot of impact on quality of life. You can also see, and you can imagine, that these are all appraisal and coping skills. These are all tasks and skills which you can learn, or at least it can be guided in by psychologists, for instance. So quality of life, like I first said, it's not something you can really touch or can really influence, but you can influence these factors and these steps you make through an adaptation process. Next slide, please. I talked about cognition. Cognition obviously often influences quality of life, because cognition can be very influential when it comes to adaptive processes. And the fact that it's there is, well, it's not only the ventral pons, but we have a lot of other areas which are included in the etiology of locked-in syndrome. And all the etiologies of locked-in syndrome is also a wide range. So you can imagine that it's not unbelievable that a lot of these diseases cause also cognitive problems. And I think they need more attention, or we should be very aware of them, because they influence the decision making, they influence the mood, and also the way patients are able to adapt to new situations. Next slide, please. So, like I said, overall good quality of life. Again, the studies are with very mixed etiologies, but they overall report a good quality of life. And that's, well, that's not unexpected in the quality of life literature, because there's a phenomenon we know as response shift and adaptation, like I said before. But again, the questionnaires that are used, for instance, and the studies that are cross-sectional are not enough basis to know more about quality of life. And what I mean about questionnaires, when you talk, for instance, about health-related quality of life, it's always related to your situation. So it's not about who you are, but it's about you in response to your situation. For instance, I know many SMA patients or ALS patients who say, my quality of life is fine when I have because I'm healthy at the moment, and when I have a pneumonia, yes, then I feel less well. And they say, well, at the moment, they fill out the health-related quality of life questionnaire in a different way. So that's good to know that it's very related to the health-related quality of life is really a response to your physical function or your disease. And a lot of patients don't feel ill at all. So they should be asked about other aspects like religiosity, or like mood or satisfaction, or wellness, and because they are more overall personal factors which also make quality of life. Next slide, please. So I come back to this, for me, important slide. So that's why I always had the position of spirituality and Hubert, because they talk about general quality of life and not only health-related quality of life. Next slide. And talking about quality of life does play a big role in hospital when you talk with families, patients, when you're able to communicate with them in hospital in an acute phase, because this is the situation they often meet, I think, because a lot of healthcare professionals and also patients who are, a lot of individuals who learn about locked-in syndrome immediately responds like, well, that's the worst thing you can happen, and that you shouldn't be living through that. A lot of literature is also stating that, but when these people find someone in their neighborhood with locked-in syndrome, their opinion often changes. And healthcare professionals, like ICU doctors who are in acute phase, don't often know, or actually, I don't think they hardly know about the situation, and the few months afterwards in patients with locked-in syndrome can respond and can, for instance, use their thumb and communicate much better. It's a different situation. So that's something to be aware of when you're a hospital doctor, to educate your fellow doctors. And because I think it's locked-in syndrome is often called, it's often named, it's a very rare disease, but also talked about in the wrong way. And you see with situations like Anne, that's unbelievable what you can do for patients and how well they feel and how high their autonomy can be. Next slide, please. So that's it. Johnson said it much better than me, but it's important to dismantle the negative view people have on quality of life and their locked-in syndrome. But it's, sorry, last slide. But it's very important not only to, but it influences treatments and advice given by medical professionals. So you must be very aware. You must be very. We must be very aware that we have to educate the colleagues, because it shouldn't be like this, that the situation about the prognosis and the quality of life and treatment is easily contradicted by the ICU doctors, for instance. I'm not saying that's the overall situation in the Netherlands, but I feel that this is one of the items we have to be aware of. Next slide, please. So I already said quality of life. Is this the right outcome measure? In the neurology literature, it's widespread, but I still think that's when you say what everyone should know what to talk about when you say quality of life, and also how to intervene in situations to improve that. And for me, autonomy or life satisfaction or participation satisfaction are much better outcome measures, much more close to the patient. And next slide, please. So what to do? Next slide. I think when I put everything, when I see what's being published at this moment and what to do yet, I think we should pay extra attention to psychological impact over time. I miss longitudinal studies, not only on participation, but also the psychological impact, the psychological treatment for depression in every phase, effective strategies for coping, for adaptability with the disease, acceptance in commitment therapy, for instance, and also focus on the social network. And more research on cognition and impact of the use of the augmented communication devices, but especially also on cognition and the way that restrictions have influence on, for instance, using difficult devices. Next slide. So I think the communication is wonderful. It's being developed at this moment, but we should evaluate over time. We should follow patients and not only follow them in the way they are using all the new possibilities, but also in the way they develop. And for instance, when you have ALS patients, that's different from patients with another etiology. But actually, without really realizing it, they change. And it's very difficult to diagnose that these changes and to realize what changes these are. And they're often cognitive or in another way. So, and the only one can, for instance, who notices that can be Bauke or a colleague of him because they notice that patients have more difficulty with using the devices. So I think that's something we should be respectful and follow these patients far more in detail, how difficult also it can be. Cognitive, psychological, and also in their skills in communications, for instance. Next slide. And we should focus on caregivers and the family perspective. That's a big subject. I think caregivers and patients and quality of life are very strongly related. Caregivers are the caregivers, the spouses, family, friends, but there are often also children in the house. And we've learned from ALS that these are the silent caregivers who often do more than you would expect. They don't communicate about it. They feel, they shouldn't because, they should do this for their parent. They're very loyal, but can be 10 years later or something, they can be really, you can hear from them that they have had a very difficult period, and they have their development, in their development and also in the psychological development, it can be an issue in like 10 years later or so. So you have to be careful with them. And they often, they don't want to report. They feel they're very loyal. So, and they do more than you think. So just to give attention to them and educate them, also by introducing new tools, they should have, they should be able to adapt to everything what's happening in the house as well. It has influence on them. Children, for instance, tell that they do not take friends home from school because they don't feel easy with that. It has influence, and I think that we should give far more attention to these children and to these caregivers. Next slide. For ALS, that's Melinda Kavanagh's work. She started with it, and she has made a beautiful information material for children from all ages. And we in the Netherlands, we translated this, and we made videos and YouTube films in which they interviewed each other and tell each other about the disease and about the impact on them. Really beautiful, and I think that it's a good idea to develop for them. I think you really because a lot of parents are worried about how to take care of their children, and that's a big burden for them. Next slide. So obviously multidisciplinary rehabilitation in the superacute phase can be very complex and very compact. Speech obviously is very important to focus on. And then you see a lot of therapies like music therapy, which, just that's really individual in what kind of program you get. And for me, I always add the fourth dimension. So 4 dimensions, also spirituality, asking patients about their values, about what is important in life. Are we on the right focus? And I think that's the fact that you ask these questions to your patient, he realizes that you mean it and that you really have focus for all dimensions of his life. And this dimension is often not talked about by patients because they do not expect you to be interested in it, and because they are also very physical focused during a long phase. So I think it's very important that we as healthcare professionals focus on all dimensions and give room to conversate about it. And I haven't mentioned it, but also like sexuality and intimacy subjects which you have to mention and bring forward and to talk about it, because it's very important for the caregivers, obviously. Next slide. So like what I would suggest is kind of this program. When you do research and innovations, you focus on care just in time. It would be very nice for patients to do telemonitoring because, Anne is certainly able to telemonitor. I think she would be the queen of that. And that would be really nice because she can longitudinal tell us about her experiences, and you can give her questionnaires. And a lot of patients also with less capabilities are able to telemonitor and fill out questionnaires, and which give you data over time. Patients with ALS have asked us to to develop this. I mean, you often think, we as healthcare professionals often think that's a burden, but patients are really willing to tell about their situation and to follow that during time. We should have a good network. We should work closely together, all the caregivers and the healthcare professionals, and everywhere a patient goes. I think we all know that when you have a lot of caregivers and healthcare professionals, you must be aware that someone is the coordinator, and that should not be the patient. And then focus on the caregivers, obviously, and the children. So for me, that would be a suggestion for the next research. Next slide. And determinants of quality of life. Obviously, I already said that. Focus on stigma, for instance, and autonomy. The IPA, the IPA, I know that questionnaire, and I like it because of its focus on the right questions of autonomy. And I would suggest longitudinal research using BCI and telemonitoring. It's there. It's for grip. It's developing very fast, and it's really beautiful. Next slide, please. So this is some of the literature, and well, I'll take questions.
Thank you very much, Esther, for such an interesting presentation. Does anybody have any questions?
I have a question, if I may. So,
Thank you.
thanks a lot, first of all, and also I was thinking I spoke actually last week with a caregiver of a person that previously lived locked in because of ALS, and we started talking about quality of life, and then she said, "Oh, I hate that word." Because it's very much a medical perspective, and my husband always felt misunderstood because he was having a good life, but he was told his quality of life was low. And in your talk, you also suggested at some point, like, is it a good word? What do you think? Should we abandon the term?
Well, yes. I mean, be aware. So what you're talking about, and your thoughts about it. I mean, well, that someone has the audacity to say to the caregiver that he had a low quality of life. I mean, probably he filled out a questionnaire, and you often see that caregivers go like this, and that the patient is in a very stable state of quality of life. But it's often the health-related quality of life questionnaire used. I think it's what he says. He doesn't know what to do with it. So that's, I think, when you talk to patients and when you want to talk business about what's important, ask them what's important. So don't use like quality of life terms. Ask what's important and strive for it. Yeah.
Fernando?
Yeah, I also had something to say about quality of life, but it goes in the same direction as your question and Esther's answer. It's a standardized questionnaire, so it has one advantage, which is what enables to generate some comparisons, but its usefulness, of course, at the individual level is very limited. So as Esther said, one has to really be very aware of what the limits of the measures are. And to begin with, it has the disadvantage of being something that is aimed at measuring something. So it has a double feature, which is that it is subjective because there is no standard of quality of life. It's just what the respondents say it is. And on the other hand, it is a measure which suggests a kind of objectivity it doesn't have. But to use with groups, generate some kind of comparison, it's not bad. So, for example, if it shows that there is a correlation between quality of life and time in locked-in syndrome, well, then in itself it's already an interesting piece of information that can be valuably used. Now, if we want to know more about the individual situation, it's of course very, very limited. So, it's just one measure. And if we are aware of its limitations, then it's just to be used with other tools, I think.
I think, Tina, perhaps you want to ask a question?
I was just going to chime in and say quality of life in just general public. Has that been polled? And is there really a difference with people with locked-in syndrome? I mean, really, I've met some folks with locked-in syndrome that are having a much better day than I am, and just I think that's something to also consider, not to peg them in a hole.
But it's very useful when you have to talk to ICU doctors, because they're stunned by the fact that quality of life is high, like you say.
Yes.
It has a strong message, but then you have to leave it and go to, when you do daily care, you ask for the determinants of quality of life, and then it becomes interesting for a patient. Yeah.
Anybody else with some questions?
I have a question for Dick, if I may ask him.
There's also a comment in the chat, maybe that's addressed to Esther, and then
Yes, I
maybe
think
after we move to Comments for Dick.
to Phil's
I
question.
can read it out loud.
Yep.
So Paolo
if
Amaro, it says, if
Oh.
communication is a human right, we would have to insist with each other of our authorities and also be able to create an international foundation to improve access to achieve communication.
Well, I fully agree. It's a basic right.
Yes, we've covered basic rights several times today, and it's very obvious that we do need to acknowledge and work towards that. Yes.
The fact, may I say something about this? I think the fact that something like the right to communication appears in a document like the UN Convention of the Rights of Persons with Disabilities provides a guideline for national legislations and national actions. So it's not, a UN convention is not, doesn't obligate necessarily the signing parties, but it pushes them in a particular direction. And as these kinds of conventions are incorporated into national law, then they gradually, generate concrete action. So it's a process, but it is very important, even if it's very abstract and very much at the level of general human rights principles, that the right to communication is in such a convention. It obligates the parties to gradually, adapt their norms and to take concrete steps. Whether that happens or not is a different matter. Nobody controls. I mean, there is a control. There are regular reports about how much, how much local legislations are adapted to these conventions, but it's still very, very important symbolically, and it's also a flag, that anytime, the people concerned can say, hello, here, it's in the convention, you're obligated by it, and so on. So it's still a powerful tool.
Absolutely right, Fernando. Thank you for that point. Anybody else before we move on to Phil's question?